I will keep it short now when introducing another major figure in the world of medicine on such a fundamental topic. And I think that all things that we've been discussing here and in previous congresses, apparently, it all ends up in our minds on our psychological impact when in pain, when with our inabilities and with our poor sleep. So, I think his name is enough good of introduction. That's Antonio Bulbena Vilarrasa, holding a chair of psychiatry at the Autonomous University of Barcelona. And later we will listen to an online patient, but first, Antonio Bulbena. Good afternoon. We have quite close to an hour of a delay, but that's no issue. But you are holding up here and with another man with a suit standing in front of you. So how am I to begin? Well, I cannot become a woman myself, but at least if only to be closer to those that aren't wearing no tie, let me take my tie off. So, the topic at hand. Every time I come here, by the way, I think maybe I should have done what I did my first time, where I play guitar. I was really scared. So maybe, given the delay, maybe, why not? Just a couple of plays at guitar, Albani's, for instance. But no, I'm here to follow the doctor's orders, and you all see, we're talking about some negative things like conditions, smoking. If you smoke, you die, and if you don't, you die as well. So, and then depression later, well, and then Mr. Ricardo would say, well, it all ends up on our minds. So probably that's the end of it all. Anyway, this is a prevalent topic I will tell you about, but let me begin by telling you how it ends. In that there are some quite good treatments and we are learning much. And this is what I wanted to convey to you in my humble opinion. And these are the items in my presentation that hopefully I will try and communicate appropriately. But then if you have any questions, I'll be willing to answer them. So, the human sickening, and so that you get a bit of a setting between myself and the patient later. Then I will talk about depression and anxiety, and then on three main areas which are specific in the world of OA, and then on two more disorders that are related to what I'll be talking about. And this is like a map to guide our way. This is Vernadsky and Chardin Stellar. What's in our world? There are minerals, molecules, arena, then the biosphere, all the animals where we are included, maybe sometimes too much, and then the conscience. And then it's not just the molecules in our leg that are doing poorly or that biochemical. No, it's not only that. We are also biosphere. We have cells, of course. But then the human sickening is not just a molecule. It's not just a cell. This is a sickening that has an impact on the noosphere. So the individual, but also the partner, the family, the group. And this is one of the perks of in this type of a congress, where you can find both patients and doctors, because we are all patients. Just because we wear a tie doesn't mean we are not patient. And I think that this is a lucky merge, and on that I would congratulate the organizers. Depression and anxiety. Just to give you a bit of a setting, 1 out of 7 individuals will have some sort of depression or depressive disorder in their lifetime. And these are the basic questions to know what depression is about. And these are questions that you can ask yourselves. As in, the last 2 weeks, have you felt sadder, or have you lost interest on things? Have you lost trust? Have you lost trust in yourself? Do you feel more tired than usual? You find it harder to focus, or you feel like life is not worth it? You feel guilt and so on. This is what we call depression, and which apparently is more visible in some rheumatic conditions. And anxiety, which is even more regular, more hidden. Apparently, that me taking my tie off made things worse. And now, don't I have a singing voice? Well, anyway, I was telling you that anxiety is more frequent but less diagnosed. If you have anxiety, and these are just your usual anxiety check questions, I mean, if you are stressed or anxious, you don't want to stay and talk things out. And like, feeling sadness might want you to, but anxiety doesn't want you to. So this is why it's so difficult, because it's not that easy as saying something's wrong in their body. And when we are saying that osteoarthritis takes some years to heal, well, it's even worse for anxiety. But anyway, these would be your usual signs and symptoms in anxiety. Usually the most well-known are stress, breakdown, or the panic when being on a crowd, or phobia. For instance, I visited a patient for the first time yesterday, and after the visit she told me, I cannot take the lift or even drive. And people do not even know unless you ask them, and it's quite frequent. As I was telling you, excessive concern, the irritability, the muscle tension, they are susceptible, they are edgy, with a greater sensitivity often. So, anxiety and depression, that's an overview. And they are much related. You can find people with anxiety when in their 20s, suffering from depression on their 30s. Treatments which are very much close and often underdiagnosed. Now, closer to rheumatology, with these 3 conditions: rheumatoid arthritis, osteoarthritis, and joint hyperlaxitude. And here I would like to appreciate the attendance of the society, because next week we'll be having precisely the meeting on that. And I'd like to thank also Eva Collado, because this is a disorder that has much to do also with mental disorders and with arthritis. This is what I mean. Rheumatoid arthritis is less frequent than arthritis, osteoarthritis, but yet we see that there is a significant percentage of depression and anxiety. According to this Egyptian paper, it was more common anxiety than depression, and there are several mechanisms that would go to explain it. This paper, published just recently in July, was looking into the mechanisms, into the nervous mechanisms and the immune mechanisms, and how they relate these 2 conditions. And even though there is more depression, there are some mental people with mental illness that don't have this condition, like schizophrenics. So what's the mechanism here? That's important, and this has been proven. It's difficult to see rheumatoid arthritis in a schizophrenic patient, but you can see depression more in them. And then, osteoarthritis, which is the focus of this Congress. And close to 1/4, maybe more, and here the mechanism is from OA to depression. There are several mechanisms that are connected, that are linked. This is what you usually see, and I guess that you all understand this. Well, OA means pain, and then if you add to this mental suffering, the issues, the challenges in moving, and of course this will have an impact, but it's probably not the only mechanism, and now we know there are more. And this is a significant one, and I'm sure that we can act upon it, but this is a paper from last year, and on genomics, they would find that these neuromechanisms, the neurotransmission, the neuroinflammation, the neurogenesis, were much related through pain to major depression. It was not just an issue of life being difficult, but also that there are some immune mechanisms that link one with the other. So let's treat that. Let's not just show our concern on that. And this is something that was published last January, and it is the culmination of a new stage opening up in this field, and this is important for patients and for therapists. What's this development? This is a Chinese paper where there is a significant genetic coexistence, genetic liability between major depressive disorder and osteoarthritis. And here 3 genes have been found. One, the estrogen gene, and maybe this is why both depression and OA is found more prevalent in women. Then a transcriber, as you can see, is working on neurogenesis and chondrogenesis, and then the peroxidase with antioxidant effects. So 3 elements that open up the possibility to work on these 3 areas. So we as doctors need to see how we cater for this. This is where we have tamoxifen. This is a well-known drug that we psychiatrists started using as an anti-euphoric medication. There might be some issues with OP, but we know that there is a psychopharmacological effect. Then statins and antidepressants, and then thirdly antioxidants, which is apparently, well, everyone should be having, but no one knows which one should we. So we know that these are promising treatment avenues and that we need to listen carefully to that. Then the Ehlers-Danlos, the joint hyperlaxitude, which has an impact on close to 15% of people, with people being more flexible, being able to bend their elbows, like for instance, as you can see here in this elbow or this leg, or people that have been able to do this with these dislocations, so bigger scars, and a greater facility in having bruises. And often this goes undiagnosed. The person I received yesterday for an anxiety attack, she was having this without herself knowing. So we know that people with this disorder that might be seen by the rheumatologist or not often have a higher prevalence on anxiety and depression. And to conclude this, what happens with our anxiety patients, with phobia, with panic attacks? Here we see that patients with anxiety, close to 80%, have this collagen feature, and this has opened the possibility to better understand what part collagen plays to the neural factors. We have tested on scent, on touch, and therefore we are measuring all the psychopathology related to it. So I think it was worth mentioning it. And again, it's anxiety and hypermobility, which are often unseen, and yet they have this genetic base. These are some published papers. But all in all, what should we do? Where's the hope in all of that? We have a good pharmacotherapy and we need to use it properly, and it's increasing because of the genetic research. Then there are some psychological aspects. I would have wanted to jump in on the smoking discussion, because the question is, why do we smoke? Anyway, we would stay here up until tomorrow, but it's important to bear in mind that we are bringing back into the world of psychiatrics substances that had been banned before, ketamine for instance, substances that have been banned every now and then because of their addictive potential, and yet they have a positive potential as well. So if you consider prohibiting a substance, you also need to bear in mind what's good in them, because we are no fools, well, to a certain extent, but we need to know what's happening with us. But anyway, this is not the topic I wanted to discuss, but I wanted to get this off my chest. We also have some somatic treatments, other than the well-known ones. We have many rehabilitating ones for anxiety, and then there are some countries that have suggested an amount of exercise on a daily basis to prevent depression, both in England, and there is a recommendation. There are recommendations both on sunbathing and physical exercise to prevent depression. These are antidepressants, and these are the conclusions, and hopefully this wasn't too long a tie for you. First, depression and anxiety are frequent disorders, not just reactions. So when talking about depression and anxiety, that's not just a reaction. Sometimes it might be, but there are so commonalities, and so they should be seen as a condition. Secondly, treatment is not only pharmacological based, and there is pharmacology, but it's also somatic, psychological, and socio-family. Then, on joint hypermobility, the Ehlers-Danlos, is very much related to psychopathology and also related to OA. And finally, as I was telling you, on this recent 2022 paper, there are some gene findings that have brought closer rheumatic condition and psychopathology. And thank you very much once more for your attention. I've seen no people falling asleep here. You managed to stand, so thank you very much. And now on to you, Don Ricardo.
Ha sido usted muy breve. Y lo muy breve,
and as we say, if short is twice as good. But now, look who's with us. We have Gemma Sarradell. Gemma Sarradell, she's a volunteer at OAFI. She is a nurse. She knows well the healthcare environment. She has taught me German every now and then. She's a jolly lady. She's a staunch, powerful lady, and she wants to be here with us. And I very much appreciate you being online, because it's important to tell people what goes on, what happens. May I ask you, how come you were not able to make it?
Of course you can. Good evening, Ricardo. Well, yes, because I'm not feeling well. I can't even leave my house. Whether it's because of osteoarthritis, well, it's probably the reason for 90% of my depression. So I'm not feeling all that great. But are you getting out from that situation? Well, yes, I'm really down, really down. I don't see myself capable of leaving my home. Now we have technologies, though. So the term being down, Professor, being down clarifies what is happening to a patient. If someone says, what's going on? And that person says, I feel down. What does that mean? Well, it's a usual way of communicating oneself. What we, the doctors, do is codify what the person says. And by the way, the patient is always right. We need to know the patient. We study, but we need to know the patient. When you're down, you need to see whether you're down because it's physical, whether it has to do with your state of mind. But we need to understand the situation, and then we can find out things. It's not the same to be down for 1 day, 1 week, in the morning, in the afternoon. When you're feeling down, and a patient says so, then we can clarify things. But you see this as a process of your osteoarthritis. Well, apart from that, I imagine that I also had a crisis of asthma. You're not a smoker, are you? No, I don't smoke. I haven't been smoking for the last 20 years or so. So I don't smoke. It all came together, you know. And I'm finding it hard to get up from bed. Right now I've spent 1 month and a half without leaving the home. Yes. And what do you think about leaving and going to buy some bread to the baker's? Or to say hello to the newspaper man? Well, I don't have the strength. I try to. I do try. Don't believe I don't. But there's no way. When I get to the door, I step back. But I have a visit with the psychiatrist to see what happens, because when one doesn't feel well, one needs to look for a solution. And the solution, I think, is this. When someone is so aware, when someone says, I can't, I'd love to, but I can't, do we need to force that person? We need to accompany that person. For example, when there are cases like this one, probably if there was accompaniment and she could go out with company at the right dose, it would be easier. Sometimes we have nursing teams that are used for this. And this is very useful. In addition, depression locks people in. Phobias do as well, or both. How many times do we see people who can't go somewhere or can go to the supermarket? So accompanying, other than forcing, is facilitating things. Because if we compare the pain and not being able to move, what causes more depression? Clearly, not moving. So, a case like Gemma's, it would be better to move. But at her pace, I mean, that's what we need to consider when talking to a professional, to find the right dose. But life is movement. And this is something to be considered. When your friends say, Gemma, you've always been a lively woman, go out and enjoy yourself. You would love to do that, right? We should be in your shoes. And you will. I'm sure you will. You will persevere. You were a speaker in some OAFI Congress, and you will be back. I'm certain of it. Do you sleep badly? No, I don't sleep well. So you're not sleeping well? I sleep badly. Occasionally. Maybe after midday, I'm sitting down watching the television and I fall asleep. A lot of medication, Gemma? No, not a lot now. But I've been taking the same medication for a long time. Maybe it's my fault I haven't gone to the doctors. Because it's when I didn't have time. You know? So now, the medication will be adjusted and we'll see. I hope to be able to leave my house. Any message you would like to convey to those accompanying us today and those that will see you through the YouTube channel? Yes, like a couple of years ago, remember? I was asked from Mexico. Yes, many are following us from Mexico. Here you can see the outreach, right, that we have. So for those of you there, take it with excitement. Move forward. Look ahead. Go to the doctors as many times as you need. Exercise. And above all, trust. Let's all trust in that we will move forward. We love you, Gemma. Look after yourself. Well, that was a testimonial, yes. And we agree in that the message is a message of hope and a message of faith. So we need to do, and we need to have hope, as Mr. Ricardo here is conveying. Professor, you can use that door over there. Thank you very much.